discuss the etiology, pathogenesis, clinical features, diagnosis and treatment of systemic sclerosis, that is scleroderma or CREST syndrome. Systemic sclerosis, previously called as scleroderma, is a multisystem connective tissue disorder affecting the skin, internal organs, and vasculature. Thickened skin, that is scleroderma, is a hallmark of this disease. It is more common in females, 4:1 female to male ratio, and the peak age of onset is in the 4th and 5th decades. It is subdivided into diffuse cutaneous systemic sclerosis, that is DCSS, and limited cutaneous systemic sclerosis, that is LCSS. LCSS, that is limited cutaneous systemic sclerosis, may have feature of CREST syndrome, calcinosis, Reynolds, esophageal involvement, sclerodactyly, telangiectasis. Etiology and pathogenesis. The exact etiology is unknown. Many environmental factors such as exposure to silica, dust, vinyl chloride, epoxy resins, and trichloroethylene have been suspected to play a role in the causation of the disease. There is infiltration of skin by T lymphocytes and abnormal fibroblast activation leading to excess collagen formation and thickening of skin, that is sclerodactyly. Fibrosis can happen in any organ leading to organ damage and functional impairment. Vessel wall inflammation and intimal thickening leads to narrowing of blood vessels. Systemic sclerosis can overlap with other autoimmune immune rheumatic disorders. Example, sclerodermatomyositis, tight skin and muscle weakness indistinguishable from polymyositis, and mixed connective tissue disease. Clinical features. Skin features. Raynaud's phenomena is seen in almost all patients and may precede other clinical features. Edematous swelling and erythema of the skin may precede skin thickening. Thickening and hardening of the skin. The skin of fingers, hands, face is first affected. Skin becomes taut and shiny. Skin creases disappear. Thickening of facial skin result in the mask-like faces and microstomia, that is small mouth. Skin involvement restricted to sites distal to the elbow or knee apart from the face is classified as limited cutaneous disease or CREST syndrome. Involvement proximal to the knee and elbow and on the trunk is classified as diffuse cutaneous disease. Musculoskeletal features. Arthralgia, morning stiffness, tenosynovitis and myositis. Gastrointestinal features. Smooth muscle atrophy, fibrosis in the esophagus lead to esophageal reflux, dysphagia and odynophagia, that is painful dysphagia. Involvement of the stomach causes early satiety and occasionally outlet obstruction. Vascular ectasia in the stomach, that is watermelon stomach, is frequent and may cause recurrent gastrointestinal bleeding and anemia. Small and large bowel involvement may lead to malabsorption due to bacterial overgrowth, bloating, pain, or constipation and pseudo obstruction. Pulmonary features. Interstitial lung disease, pulmonary hypertension leading to progressive dyspnea, right heart failure and angina. Increase in the incidence of lung cancer. Cardiac features involve right heart failure and angina due to pulmonary hypertension. pericarditis, myocardial fibrosis, arrhythmias. Renal features include proteinuria, scleroderma, renal crisis. This is a life-threatening renal disease and is more frequent in patients with DCSS, that is diffuse cutaneous systemic sclerosis. It is characterized by acute onset of renal failure and malignant hypertension. Neurological features include cranial entrapment, peripheral and autonomic neuropathies. CNS involvement including headache, seizures, stroke, vascular disease, radiculopathy and myelopathy. Genitourinary features include erectile dysfunction in men, decreased vaginal lubrication or constriction of the vaginal introitus in women leading to dyspareunia. Diagnosis: systemic sclerosis is mainly a clinical diagnosis based on the presence of typical skin thickening and hardening, that is sclerosis, along with the presence of extracutaneous features and characteristic autoantibodies. ESR is elevated. Anemia may be present. Skin biopsy is usually not essential but required if the diagnosis is in doubt. It is also helpful to differentiate from other causes of skin thickening. Autoantibodies. Presence of many autoantibodies support the diagnosis of systemic sclerosis. These include anti-centromere, anti-topoisomerase 1, SCL70, anti-RNA polymerase or U3-RNP antibodies. ANA with a nucleolar staining pattern is frequently present. X-ray and CT scan chest if there is suspicion of ILD. Echocardiogram to rule out pulmonary hypertension and cardiac involvement. RFT and urine analysis to rule out renal damage. Management: regular monitoring of BP, renal function tests, and blood counts. Intravenous cyclophosphamide has been shown to slow the progression of the disease, but the drug has significant side effects. Corticosteroids and immunosuppressive agents are indicated in patients with myositis or interstitial lung disease. Raynaud's phenomenon: avoidance of cold exposure and use of vasodilators such as calcium channel blockers, which include nifedipine, amlodipine, or angiotensin II receptor blockers, example valsartan, may be helpful. Sympathectomy may be tried in patients who do not respond to medical therapy. Esophageal dysmotility and acid reflux. This can be improved by proton pump inhibitors and prokinetic agents such as itopride. Infection of ulcerated skin should be treated with prompt antibiotic therapy. For severe digital ischemia, intermittent infusions of ipoprostenol may be helpful.